Good morning, good afternoon, good evening, wherever you may be. This is Firoz Manji from the Raja Press. Welcome to Organizing in the Time of COVID-19. Today I have a special guest, an old friend and comrade, Rene Loewenson. Rene Loewenson is a Zimbabwean epidemiologist and director of the Training and Research Support Center. After teaching for a decade at the University of Zimbabwe Medical School, she led a health department in the National Trade Union Congress in the 1990s, worked with the African Continental Trade Union body in health programs, and is a founder member of EQUINET, the regional network for equity in health in East and Southern Africa. She has since 1980 implemented research, participatory action research, policy analysis, training, negotiations on law and policy reform, and has led and contributed to various international consortia on equity in health, social determinants of health and health systems, on social participation in health, on policy change in family and child health and well-being, and public health law and practice. That's what she does in the mornings. What she does in the afternoons, we will soon find out. But she is also the leading light on the production of an extraordinary series of publications that speak to the situation of COVID-19 in Africa. And I think it's probably the most unique resource that is currently available on Africa. So it's with a great pleasure that I welcome you, Rene, to Organizing in the Time of COVID. Welcome. Thanks for sparing time to meet with us.
Oh, thank you, Feroz. Thank you very much, and it's such a pleasure to be here.
That's great. Now, well, we don't get to see each other very often, so it's nice that at least we've been able to do it virtually.
Yes.
So, just perhaps as a way of starting, just say a little bit about EQUINET and what led you to produce these unique reports over the last few months.
Ooh. So EQUINET has had quite a long history. Its current form started in 1998, and it's a network that brings together a range of different kinds of people, civil society, governments, parliamentarians, trade unionists, technical people, researchers, academics, all united around the value of equity and health. People who work in different disciplines also, around trade, around health services, around participation, etc., around food security, gender rights, human rights, law. So, and it's all around equity and health. And I think right from the very beginning of the COVID pandemic, and EQUINET's been going for several decades now, but we really saw from the beginning of the COVID pandemic that equity was going to be a central issue, that COVID and the inequality that we see not only within countries but between countries was going to be the fault line through which the pandemic would move, and that the things we had diagnosed as the root causes of some of these social inequalities, like neoliberal economies that were putting money above people, thinking that success was measured in GDP growth rather than in human development, and the sort of privatizations and commodifications of so many aspects of our lives that led to people not having decent housing, decent work, decent water supplies, decent sanitation, decent diets, decent employment was going to become a source of susceptibility to COVID. So we were very much stimulated to track what was going on, to report what was going on around the pandemic. And indeed, over time, from initial kind of documents that were really just sharing information, because people were asking, what is this thing? We were also increasingly trying to share what was happening, what we knew what was happening, but also what were the responses. And not just the problems, but also some of the ways people were responding to it, and some analysis around that. And I think it's an ongoing story. I mean, I think the story of this pandemic is by no means over. And so the task continues to keep doing this. And the good thing is we're a collective. EQUINET brings many talents and capacities together. So we have a possibility in all the 16 countries in East and Southern Africa to draw and learn from each other and share experience, but also to engage globally around these issues. We wanted to tell the story from our region's lens as well. You know, there's so much written about Africa from non-Africans that we also felt the need to say this is the way we see our region. This is how we see things.
Yeah. I mean, if one looks at the sort of mass media, the corporate media, what we've been fed is a story of, oh, you know, Africa's going to be torn apart, destroyed, and so on by COVID. There's an emergency that's required, and then a few weeks later, we get a whole series of stuff published, some of it from Africans themselves. About an essentialization of Africa. That, you know, well, you know, Africans are not getting the disease; they're immune to COVID-19, and you know, so we don't need to worry. So you had these two contrasting aspects. So what really is going on? What do we know about COVID-19 across Africa?
Okay, that's a huge question. And Africa is a huge continent. And people tend to talk about Africa as though it's a country. But it's made up of very diverse situations. From experiences from North Africa, East Africa, Southern Africa, West Africa, vary quite significantly. And even within the regions, there is quite big variation. Within these different sub-regions, and even within countries, there are micro-epidemics and micro-pandemics, if you can call it that way, that are taking place. So one lesson is not to overgeneralize about our continent. You know, having said that, I think that certainly speaking for East Africa and Southern Africa, we have a lot of movement of people and a lot of interaction between the countries of the region, so that what happens in one country is important for the other countries in the region. Our public health futures as a region are quite deeply linked. And part of that is because of the experiences of colonialism and the way countries are engaging in globalization, that we are experiencing some convergence around that as well. So I think it's some of this is about teasing out where we're different, and also looking at what is underlying it that's actually in common. In speaking about the pandemic, I think I heard WHO Afro reporting last week that there were 3.5 million cases in the continent and 88,000 deaths since the start of the pandemic. And that probably North Africa and Southern Africa are more affected than East Africa. And even within Southern Africa, that there are, you know, experiences like South Africa has been more affected. That countries that are more globally integrated, like Kenya, through travel hubs like Nairobi or Johannesburg, certainly had a much bigger experience of first wave pandemic. We've had, in 2020, there was a wave of the pandemic. In late 2020 to early 2021, there's now been a second wave of the pandemic. But let me come to your question. I mean, this notion that either, you know, Africa is the continent where everything goes bad. Therefore, you know, people were predicting dire scenarios and then thoroughly confused when it didn't happen, and looking for explanations is part of this treatment of Africa a source of all problems as an emergency situation in and of itself is just part of this global stereotype, sensational media stereotype. But it's a mixed situation. So we don't know, we don't really have good proven explanation as to why the case levels in Africa in terms of severe infection or mortality have been lower, and they have been lower. But there's a number of explanations. I mean, African countries certainly were faster in reacting to the closure of borders and the importation of cases than many other countries globally, including, by the way, countries that scored much higher than many of the countries in our region on the capacity assessments in the international health regulations reviews. African countries have had prior experience of pandemics and Ebola, etc. More rapid responses on surveillance and on the measures required. So I think there's been a sort of a quicker state response on the early measures that stopped some of the early local transmission. And as I said, some of the countries are not as embedded in global travel hubs and so on that allowed migration in of the virus. But it's true, we have a more youthful population in the continent. And there's some talk about sort of higher exposures due to, I mean, high exposures to other viruses and bacterial infections creating a more effective immune response in the population. I mean, there's a lot of different explanations around this, none of which I've seen properly validated. But I think we have to also recognize that the testing levels in the continent are lower than some of the other settings in other regions. I think WHO report that the normal desirable level should be about 10 tests per 1,000 population, and that about 20 countries in the region, in the continent, don't reach that, and many other countries are just above it. And I think we're seeing the effect of that in that we're really probably not picking up the cases that are taking place, or we're picking them up in a very variable way. And by the way, the reason the testing levels are very low is because we can't access the reagents. We don't access the reagents because of the patenting systems that are, that we become importers of these things. The costs are high, etc. Which is part of the reason for your very good interview last week around the TRIPS waiver, why we need this TRIPS waiver. Because there's no question we need to produce locally, given this competition that exists. So I think we're not detecting all of the cases. But it's more important that if we're not testing, we're also not picking them up to prevent the transmission and the pandemic spread. So, and the other thing is, I'm not sure whether we're detecting all the deaths. They might be, we already have a high background level of respiratory problems, pneumonias, etc. So until we know what the excess deaths are, it'll be very difficult to understand how far this pandemic has really affected mortality in our region.
But that's a question I wanted to pose to you. I mean, yes, and that is why is it so difficult to get data on excess deaths? I mean, when people die, especially in the urban centers, in the ghettos and so on of our cities, there's only one way. I mean, they are registered, they are taken to the mortuaries and so on. So, I mean, surely there's data available on excess deaths. I mean, it's a crude measure, but at least will give you some idea of the impact of the pandemic.
I think it will come out in time. I mean, it's just the case that in many countries in the region, the registration and reporting of this is not as rapid as it is elsewhere. I think the one country that reports to the human mortality database or these international databases is South Africa, because the Medical Research Council is actively gathering and reporting this information. In other countries, it's sitting on paper records, and there's a whole issue about how this gets turned over, reported. It's not just mortality data that gets reported late. I was looking on the international databases, the WHO databases, to see the reporting of pneumonias or of a life expectancy. It's all out of date. I mean, it's all 2018, even the World Bank databases, 2018. So we just don't have recent data put in public domain in our countries. It may well come out over time, and it's certainly something that we should be collecting. I mean, the other thing is that I think that we put a lot of attention on birth registration because it was so critical for many issues, for knowing, for catching, for immunization, for child health, etc. I'm not sure we've had as much attention around death registration as on birth registration. So my understanding is that it's still not as effectively, not as universally covered in terms of the formal registration systems as birth registration in our region.
So, as you pointed out, there is it's a very diverse continent with very different situations, both politically and economically in different parts. So it's difficult to make generalizations, but it might be helpful to get some understanding of where do you think there's been good practice in terms of trying to deal with the pandemic? Are there good examples that, okay, they may not be perfect, but which give an indication of the seriousness with which our governments are taking the pandemic?
Oh yeah, I think there's a fair amount of good practice. I hope we'll come back to this question about the impact on our countries and on our populations, though, because I think we tend to focus a lot on data on COVID, but actually the impact in our region goes well beyond the virus and its particular behaviors and its morbidity and mortality impact. I think that there is and I'm raising this because I think it comes to your question about where's there been good practice, is that there is a massive health debt growing in other areas. There is an economic debt growing at household level and at national level. There are long-term issues. I mean, there are issues about youth mental health and stress, about, I think we have a public health emergency that goes well beyond the number of cases of COVID that we're going to have to deal with as a result of the pandemic. But to look then at sort of the good practices. So in all of the experiences that I'm aware of, I think that what we're seeing is a kind of not just the state, but a state-public interaction, that the positive practices are about a cooperation between the state and the public. And I think you can't talk about state practice around public health without talking about the public. So they've happened at different levels. At local level, we've seen cooperation between local governments and civil society and communities in a number of different ways. So I think there have been stories about the role of community health workers, of village health teams in Uganda, of local community groups organizing, of civil society organizing around the return of migrants, around helping people use services, around spreading information, about uptake of testing, about support for food supplies, solidarity support, etc. And I think a lot of these local action networks, where they've worked well, have worked better because they get into a positive interaction with their local governments. That isn't always the case. In some cases, the local systems might see community organizing as a threat. But I think we have enough stories from different parts of the region to say that there have been this kind of local interactions that have worked well. And also, I think we've got experiences of local people organizing to create communication channels. I think in Senegal, there's a really interesting app called Sunacity about how people can report issues to their local authority, but also get information from their local authority. We've got examples from some countries in different parts of Africa, where communities are making masks and personal protective equipment for health workers, for local government health workers. So there's a lot of that kind of energy, but I think we've also had national level responses. So, and I talked about that a little bit earlier, where states have leveraged the learning from other pandemics to come in quickly and protect their population through surveillance or port health measures and so on. I think in our region, in Southern Africa, Eastern Southern Africa, for example, we've seen that in Uganda, in Mauritius. There was an incredible program of very widespread local information, outreach to households, detecting cases, testing. They've had very low levels of the pandemic as a result. I understand in Kenya, there were measures to recruit health workers and reduce VAT and income tax. And I heard, and I'm not sure about this, but I was told that some members of the national executive even took a salary reduction. Human rights organizations have been engaging with states. We learned of the story from Ivory Coast, where human rights organizations engaged the Ministry of Justice around COVID in the prisons and worked with them on a prevention program and also on decongesting the prisons by early release and so on. So there's these sort of interfaces, but I think we've also seen it at regional level. I was really impressed when I read the stories about how when the UK variant was discovered, how European borders closed to UK cargo traffic, and there was this massive buildup of cargo. And I thought about how the East African countries had, way back in 2020, developed a regional COVID PCR testing approach where it was on your smartphone. So drivers could cross borders across the whole region without having to have individual testing. These were things that had kind of been thought about because of earlier experiences of pandemics that were put in place much more quickly than higher income countries, or the current work that the Africa CDC is doing to share genomic testing capacities in Africa to build laboratories so that they can improve genomic surveillance of new variants, or they've been coordinated strategies to procure reagents and medicines and now vaccines. And I heard last week that ECOWAS is setting up a measure to do price controls on PCR testing because there's this rampant price variation in the price sector around something that people want. And it's another barrier to testing, by the way, is that who can afford to pay $50 to $60 for a PCR test, for a test for this? So I think there's quite a lot that's been going on. What's been really impressive for me is where this cooperation has kind of strengthened the global engagement. And I think we saw a little bit of it in the World Health Assembly last year. Hopefully we'll see more of it, and more so now in the TRIPS waiver organization, where I think civil society and governments are pulling together around it. So I think there's this cooperation, but I mean, we are engaging essentially with structural factors that are causing inequalities globally, nationally, locally. And we're trying to do it with states that are under-invested in all the key areas that we need because of the neoliberal economies, in housing, in transport systems, in social protection systems, in health systems, in public health, in primary health care, in food security. All of these things have been problematic because of decades of underinvestment, because of first structural adjustment and then the neoliberal economies. And it's interesting, I've been reading some recent literature that suggests that countries that have less, that have been affected less economically from the pandemic are those that are more diversified and more locally integrated. Countries that are more globally integrated, that are exporting their products more, have been significantly more affected by these supply chain problems and export problems, and those that are exporting minerals, etc. That there's something about the path we took away from our own kind of inclusive economies towards this neoliberal economic approach that has had a very damaging impact in COVID. So it'd be very interesting to see how much we can find out more about this and really explore it. We already showed it was damaging for food security and nutrition. Now it's kind of showing another lesson of this around COVID.
Indeed, indeed. One of the things that came up in several interviews in India and Indonesia and elsewhere has been the fact that there's been a crisis in that many farmers were unable to get their produce to market because of the way in which they were prevented from coming into town. And what was explained to me was that what you saw was a double crisis. One was farmers starving because their source of income had gone down, and a whole amount of vegetables and fruit having to be destroyed. And on the other side, people living in the poorest part of the cities unable to find food. And so a crisis for them. And therefore, inevitably, when there's a shortage, of course, the middlemen increase the prices. So that's been very dramatically described in South Asia. Are we seeing the same thing in for example, in Zimbabwe or in Tanzania or in Kenya?
So I think we already know that in our countries, we've had a shift in food systems away from more local food production towards imported foods, processed foods, commercialized foods. And we're seeing it in the rise in levels of obesity and malnutrition in the same settings. Because of quality of diet, we've seen rising food prices. So this is not, these change in food markets, especially as we tend to consume what we don't produce and export what we do produce. So this is building on a kind of a background of a food problem where you can actually find that food producing regions have sometimes some of the highest levels of malnutrition in our region, in our countries. Having said that, there is no question that COVID has interrupted supply chains, and also where you see a lockdown, which has blocked people from moving to food markets, including informal food markets, when informal traders have been prevented from selling food, then of course there's been supply problems. I think there've been quite a number of initiatives taking place to organize around that. I think that I know of some that have been more formal, such as the Food First initiative in Cape Town that made a link between the local small-scale farmers and the local communities by helping to organize transport between them. And actually, that's a similar model to, I know, that's been implemented in parts of India as well, where organizations have helped to make the connection between small-scale farmers and communities to cut out the middlemen and help to enable the transport. And in fact, it's brought better quality food at lower price to those communities. What I'm aware of is that people organize collectively to solve their problems to a greater extent. So this kind of ability to find connections between food producers and local communities is something that I think is going on informally across the region, in whether not always in as organized a solidarity manner as the Food First in Cape Town. Having said that, though, I think it kind of begins to demonstrate something to us about how we're handling food in urban areas. We've always had a problem with urban agriculture, how to handle it, what to do, etc. It's not just a question about COVID, it's a question about the broader ways in which our economies make the links between those local small-scale producers and communities. So I think it's something that's going to become an increasing matter of public dialogue and debate from COVID. I mean, like COVID is opening up things that have been going on that we should be actually looking at to a greater level. And it's also showing the extent to which the informal sector is playing a role in some of these areas, that shutting down the informal sector, locking down the informal sector as a response to COVID is potentially damaging at a much wider level in terms of food markets, etc. So the question for us is, how do you enable the informal sector, enable it to have decent water supplies, decent vending points, etc. And I just want to say that this is particularly important because women are often the main food vendors. They're also often the main small-scale food producers. They're also the main carers. They're also the main people who've been experiencing some of the kind of the demand on what happens in the home as a result of the pandemic, not just the disease, but actually the response, the lockdowns and the childcare and the elderly care and so on. So I think this is something we've been arguing for in EQUINET for quite a long time, is the whole way we understand food sovereignty in our region, and how we integrate urban areas into these much wider rural models of food production, food consumption. But I do think that there's quite a lot going on. One of the things we've tried to do is to expose what is going on, but it's evident that there is much more going on than is reaching the public domain on this sort of area. So I hope other listeners will bring forward stories on this. I think it's an important area that we tell stories on. We're building a different kind of future through those stories.
I'm speaking to Rene Loewenson, Dr. Rene Loewenson from the Network for Equity in Health in Eastern and Southern Africa about the situation in Africa in relation to the spread and impact of COVID-19. Rene, one of the characteristic responses that we've seen in a number of countries, including Kenya, in South Africa and elsewhere, has been the meeting the pandemic with violence, the locking down militarily, the increased use of force, and in some cases, a greater mortality rate from the actions of police than of the pandemic itself. Although, of course, that is a feature of the pandemic. I wonder if you could sort of understand, why is that? Why is violence the sort of first instinctive reaction to any crisis?
When you say instinctive, I actually think it's been historically induced. I honestly feel like we need to reclaim our states from these historical conditions that make them behave in the way they behave. But let me explain. And for sure, there have been UN reports of the level of violence, of violations of human rights abuses in the pandemic, including by sections of the state. But I want to look at two underlying causes. So one is that we cast this pandemic as an emergency, as though it was sort of unpredicted and that we didn't expect it. It wasn't a short-term emergency. We could have predicted it. In fact, I think some people have been predicting it. We may well have more like this because of the kind of underlying factors. But once you frame something as an emergency, it becomes labeled as a threat. What you start seeing is the use of military language, about narratives about fighting the enemy, about beating it, about destroying, etc. So these sorts of things mean that by implication, anyone who doesn't follow the line is a traitor, as is the case with military narratives. So part of it is the kind of the way we've narrated the pandemic and the way we respond to emergencies. And we certainly do bring militaries into emergencies. We've seen it, for example, with the impact of cyclones, the role militaries can play in helping with logistics and so on. But when you're talking about a long-term pandemic like this and a health situation like this, that has its roots in the social determinants that people are living and working in and moving in and so on. And the military is really, beyond helping to assist with supplies, have no role to play in the community. And it's local relationships that matter. And then, so I think part of it is in the narrative and the emergency framing of this. And I know we have to talk about public health emergencies, but I think we don't sufficiently recognize the roots of these emergencies. And then, and as a result, we don't prevent them. And then secondly, you know, our public health in our region came from this very early public health from colonial periods that was embedded in public health law. That was a kind of command and control approach to public health. And it was implemented during colonial periods in a very coercive way. People were segregated, the law was used to knock down structures that were seen to be unhealthy. Infected people were seen as verminous. You would even find those sort of words in the law. So right now we are in the processes of changing these public health laws because we've had experiences of comprehensive primary health care, of the participatory approaches, of human rights-based approaches. But I think we still have this legacy of command and control public health. And it's being used you know, we've seen militaries being involved in cholera in our region to clean up cities and so on. It's something which we're still in a process of trying to deal with. And I think if we can acknowledge it and actually recognize that you cannot implement public health in a sort of coercive way, that public health only works, especially in these sustained processes, through participation, through public involvement. And so it leads me to feel that these violent coercive type responses, and it's not just violence, it's coercion as well. It's lack of information, it's lack of participation, it's lack of recognition of the determinants, the underlying causes of problems like pandemics, epidemics, is that they actually reflect a sort of a sign of state failure or state inadequacy, that decades of underinvestment in our public systems that mean that we tend to see the public as objects to be controlled rather than partners to work with, rather than people who have a role to play. It's a sign of a sense of inadequacy that we are not prepared to deal with this, therefore we have to be coercive, we have to be violent. And I think that we have to reclaim our states. We have to reclaim the public investment in our states. We have to build robust states that work for the people, because it's a real sign of state fear, in my opinion, of a threat in which they've mixed the public as being the threat, not the virus as being the threat, and certainly not the underlying determinants of what makes us susceptible to the virus as being the threat. So I think we have to really keep pushing that this pandemic is not an emergency, it's sustained, it's coming out of deeply rooted factors in our society. And we have to keep pushing attention to those factors so we don't have the same problem recurring over and over again. For me, the violence is a symptom of that.
I mean, I think what I'm hearing you say is something that has been repeated over the last year with people that we've interviewed across the world. And that is that this pandemic is actually, as one person put it, moving the blinds from our eyes. We are able to see something about the nature of the countries we live in, their political economy, its social nature, that was been there all the time. But now we have a better understanding. And I think the point that you are making is really important. Yes, there is the COVID pandemic, but it's exacerbating a much deeper and profound problem that our countries face. Would that be an accurate summary of your position?
Very much so. And I think we tend to have been so focused on the things we don't know about the virus that we aren't focusing on the things that we do know, but we've been consistently ignoring for a long period of time. I mean, take the discussion you had last week about patents. So we know that if you can produce locally, you can access technologies. But we have been ignoring that and persisting with a system of patenting that stops local production. And to some extent, we have been complicit in the region with thinking we can keep importing the things that we need. And the pandemic has shown us of the fallacy of that kind of approach. And we know you need to live in decent housing, ventilated housing, with safe water, with decent transport systems, with, you know, not just because of COVID, because of cholera, because of typhoid, because of all the other kind of problems we're facing. So, but we ignore it because we keep getting sort of drawn into other bodies of what can I say, other ways of explaining what success should look like. So I think this is not just opening up our attention to understanding, but it's opening up our attention, perhaps even globally, to the fact that we should stop ignoring the things that we know. That we really have to have some kind of a deeper push around the kind of collective interests and the kind of interdependency that we have in our society. That means that it's at peril that we ignore these things. And I think it's not just at peril within our region, it's at peril globally as well. And no less because of what's coming with climate and ecological destruction that we're in the middle of as well. So perhaps this has been a good opportunity to think more carefully and to build alliances and to build connections around what we've been saying and knowing for decades, actually. Around what kind of futures we want for our region and for ourselves and for our young people.
You mentioned earlier on about prisons and how that particular population is facing really serious problems in relation to this. And I'm very grateful to you for finding time to spend with us today, because I know the mining in Indaba in South Africa is taking place right now.
Yes.
But I just want last question really to say, how does this conversation relate to the issues that are likely to come up at the mining in Indaba? What are the populations that are being affected? What is being organized?
Yeah, so the mining in Indaba is presenting really interesting information of experiences of people, particularly people at grassroots level, communities, mine workers and ex-mine workers, around the pandemic, around the way the mining sector, which has historically externalized many of its health costs to the wider communities, has responded to the pandemic, is being affected by the pandemic. A lot of really interesting empirical experiences coming out. It's showing at even higher level the need for organization, for the kind of organization we've been talking about across many AMIs. But I think it's also, and I understand there's a session, I think it's today or tomorrow, on the right to say no from Benchmarks. And I think it's also raising this whole question about extraction, about the way in which extraction is making us vulnerable to pandemics. And I hope that we will have more discussion of this at the AMI. That extractive, there's an interesting paper that was produced by a colleague from Harvard that of the close link between the COVID pandemic and extractive economies, of the kind of extraction that's been going on historically for centuries, but also in the sense that extraction and extractive economies are pushing populations into more intense, more intense spaces, more proximity with animal species, more ecological degradation. That's actually breeding grounds for such pandemics. So I think we have a deeper issue to engage in the AMI, and I think some of the sessions will hopefully do that, about the link, not just this empirical experience of COVID, but the way we organize around how we move away from this kind of extraction of all our resources for health from our region, our diverse resources, not just mineral, but actually our food, our knowledge, our water, our genetic material, our biodiversity, to reclaim those resources, so that we are not so susceptible or vulnerable to these kind of pandemics in the future. And it's great because I think the AMI has,
and that leads me to the sort of final point.
Local community people involved.
Well, it leads me to my final point I want to raise with you. I mean, one of the things that's come up in a number of interviews is that, you know, we are dealing with is a virus which is zoonotic. It's transmitted from animal to humans, and it's directly related to deforestation, large-scale industrial agriculture, large-scale industrial animal farming, and all of these themselves are major contributors to climate change. And you've already talked about the way in which the pandemic has revealed so in injustices in relation to our own countries. What now are the potentials for cross-sectoral alliances? Yes, EQUINET is doing a fantastic job in relation to the struggle for equity in health, but health is only one manifestation of a much larger paradigm. Do you think the situation is now one that favors the building of these kind of cross-sectoral alliances, which, after all, without which humanity is fucked? I mean, I can't think of a better word.
Yeah, without question. Let me clarify, by the way, EQUINET is working on health and well-being. And well-being is not just about health in the sense of healthcare. It's about your food, your urban areas, your urban planning, and it's about all the disciplines around transport, around housing, around trade, etc., etc. So we are not focused entirely on the health sector, although I've given quite a kind of more public health focused intervention today. I hope I keep connecting with these broader areas. Are we going to make the link? I mean, what worries me is that we have two competing paradigms going on at the moment. We have a paradigm that says that we'll solve everything with technology, with biosecurity driven approaches. And I think we're in the middle of a kind of real debate about vaccines that are almost positioning vaccines as a kind of magic bullet that will solve COVID, which is not the case. I mean, and it's a topic of another discussion that we could have, is that vaccines on their own, as we are finding out, are insufficient. But we also have this other paradigm that says that we have to go upstream. We have to look at these social determinations, these social determinants, the politics of our countries, of the rights we have, of the way people are organized, and the way people organize material production and the way we consume, because it not only affects pandemics, it also affects environmental degradation. What we're calling climate change is kind of a whole kind of deeper issue of our degradation of the spaces we are living in and working in. And that I think that we're getting this big competition, and you can see it even in international dialogue, between the desire to just keep things as they are. I think we talk about building back better, but nobody wants to go back. We want to go forward. And for me, the potential lies quite a lot in young people. I think the youth strikes around some of these issues, the youth organization, the youth who are going to inherit whatever this future world is, based on the choices we make today. We're doing work in EQUINET on trying to bring that kind of dialogue to young people, and it's something we're developing this year. It's a battle for ideas. I think there are huge interest around it, and it's an ongoing struggle. I think if we can analyze and be clear about the fact that there are different ideas, different explanations, that we align around ideas that are going to take us into longer term futures, and then we find ways of showing the alternatives, which is what we're trying to do in EQUINET, constantly show the alternatives, show the options. Then I think we have an option of working with across many different communities, and that's what we're already doing, and we are learning from other people like the African Center for Biodiversity, the Environmental Lawyers Association, excuse me, many others. So absolutely, we have that possibility now. We have that window of opportunity, and we have that strategic necessity to do so. The test of our value will be in the extent to which we do it.
Well, Rene Loewenson, as I've experienced over many, many years, we start a conversation, we could go on all day. And it's always really stimulating to listen to you and to, excuse me, to engage with you on these really, I think, central and really important issues. So, I'd like to say thank you so much for sparing time to join us. For those who are interested, and I think it's essential, it's essential that you go to equinetafrica.org for further information, and there's exceptional material there, and subscribe, because these important regular monthly updates of the situation of COVID and in Africa, raising all the multiple issues that we've been discussing here, is a vital resource. So I'd strongly recommend that you go to the website and subscribe there. Rene Loewenson from EQUINET Africa and from TASK, thank you for joining us for an excellent discussion. Thank you.
Thank you, Feroz. And let me recognize the whole collective of people in EQUINET that contribute to all the ideas I've been communicating. There's a huge volume of really creative people in our continent. So it's been a real pleasure, and greetings from all of them as well. And as we say,
okay, well, we'll be speaking. Luta continua, the looting continues, yes. And on Thursday, I'll be talking with somebody I spoke to about a year ago, Mustafa Hanaway, about the crisis in COVID and the poor areas of Montreal. So please join me then on Thursday, 10 o'clock Eastern Standard Time. Thank you once again, Rene Loewenson, and I look forward to us connecting again.
Thank you for